My name's David Davis. I'm the chairman of the Red Line Group, and it is a distinct pleasure to introduce to you for this evening's talk, a webcast, Uchu Meade, who is a great supporter of the Red Line Group. She speaks either at our information days when we have them, or indeed on these webcasts. She does it every year without fail, and we're extremely grateful to her for that. Uchu Meade is the head pharmacist at St Mark's Hospital. And over the years, I think he started out as a senior pharmacist, then lead pharmacist, and now head of pharmacy at St Mark's, and richly deserved promotions, I'm sure. But an extremely experienced pharmacist in the area of intestinal medicine. Uchu's going to speak to us tonight about a topic that I've forgotten, so I'm going to read my notes, if you'll excuse me. Keep taking the tablets, a guide to the best drugs and when to take them. And I have to say, on the forums and on the Red Line Group forums, we get so many questions about pharmacy in relation to pouch and pouchitis. So it's a great opportunity to hear once again what's been happening in the world of pouch pharmacy. And without further ado, I'll hand over to Uchu again. I'll thank you for speaking to us tonight.
Brilliant. Thank you so much, David, for your very kind introduction. And let me see if I can share the screen. Okay. Can you see this?
Yep, we're seeing the PowerPoint now, yes.
Brilliant. Okay, and then the next trick. Can you see this?
Yes.
And is it moving?
Yeah.
It is, yes, yep.
Perfect.
Perfect. Oh, that's good. Okay, so technical issues resolved. So perfect. But I just want to say thank you so much to the Red Lion group for inviting me to speak. It's an aspect of my role that I really actually quite enjoy, which is patient education, patient consultations, and actually listening to patients. I feel we can learn so much from our patients. And I also think it's really important that our patients feel supported and that they feel listened to, especially by the healthcare professionals tasked to look after them. So it's really an honour to have your invitation again to be asked back to present to you. So thank you very much as well. So for this session, I know that the title of the session is Keep Taking the Tablets, a guide to the best drugs and when to take them. But my concern was I didn't want to list lots of different medications that I felt that you should be taking because everybody is very individual and those decisions should be made by your consultants or the MDT that's looking after you, whether it be nurses with pharmacy input or dietetics as well. So what I've decided to do is to really tailor the session into trying to empower you as patients. So when you are prescribed medications, you understand a little bit more about them in relation to your conditions and give you kind of questions or a different way of thinking about medications compared to patients with full GI anatomy and physiology. So I'm going to go through some pharmacokinetics. What is this? Why is it important for pouch patients? Why do we use different routes to administer drugs? I'm going to go through some classifications of medications, and this is when we'll talk about a few medications and what you need to avoid or ask questions about as if you have a pouch. We'll go through some prescription costs, the most up to date, go through some over-the-counter medications, lightly touch on medication in pregnancy and breastfeeding, and then look at where to find information. So pharmacokinetics. What is pharmacokinetics? So it's the movement of medication within the body, and feel free to ask lots of questions about this, and I can go through it. But I'm going to go through this really hopefully in a patient-friendly way. I practiced this on my mother-in-law at the weekend, and she understood it. So fingers crossed, I've pitched it just right. So all medications are designed to target certain cells and receptors within the body. However, in order to elicit that pharmaceutical response from the targeted cells, we need to have sufficient amounts of active drug, the active drug form of the medication must reach the site of action to elicit a pharmaceutical response. Having said that, the target receptors can be found all over the body, including some drugs have target receptors in the GI tract itself. But the main important one to remember is that you need to get sufficient amounts of the active form of the medication must reach the site of action to elicit a pharmaceutical response. So just to explain briefly about the basic principles of pharmacokinetics, you have and the movement of the medication throughout the body. It's a bit of a journey. The first stage in this journey is that the drug needs to be absorbed. So let's say you take a tablet, the active form of the drug needs to be absorbed from the GI tract. It then needs to be distributed around the body. And again, this is making sure it reaches the right site of action. It's then metabolized predominantly by the liver to break it down to an inactive form, or a form of the drug that can be then eliminated from the body. The main form of elimination from the body is via your kidneys. So that's the journey that the majority of medications make. So why is pharmacokinetics, or why are pharmacokinetics of medication so important for patients with GI disease? So it's because the most common route of medication administration in the world is the oral route. So via tablets, capsules, liquids, effervescent tablets, enteric coated, blah, 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 you name it. That's the route that majority of medications are formulated in. And for us, it's the start of the journey that's most important, which is the absorption from the GI tract. The majority of medications are absorbed from the jejunum, which is the second part of the small bowel. Now, the absorption, taking you back to some basic physics. So if you have a higher surface area, you will get more absorption. And also, if you have a slower transit time from the stomach or the small bowel, you get more absorption. So why are these two important for us is that we know that some patients might have reduced surface area because they've had sections of their bowel removed, or the sections of their bowels that has disease within them. So that surface area isn't of a good quality for absorption of medication. Also with vitamins, minerals, and trace elements. But for this presentation, I'm just going to focus on medication. We also know that some of our patients might have an altered GI physiology. So they might have a faster transit time, which allows less time for the drugs to be absorbed from the small bowel. Please, is everybody following this at the moment?
I definitely am.
Okay, brilliant.
It's good to ask. I think if anyone isn't following it, then please drop me a line on the chat, or indeed shout up now.
Yes, yeah, I'm happy for you to do that. So the next thing that's really important within pharmacokinetics is a concept called oral bioavailability. Now, oral bioavailability is the amount of medication that reaches the systemic circulation. So when I talk about systemic circulation, I mean your blood vessels. So let's say that you take a tablet, and it's the amount of that active drug that hits your systemic circulation to be distributed to the site where it will elicit a pharmaceutical response. So any drug that comes to that has a license within the UK will need to have studies to demonstrate that the drug has good oral bioavailability in order for there to be sufficient amounts of active drug at the site of the receptors where the drug can elicit a pharmaceutical response. However, unfortunately, or fortunately, which way you look at it, these studies looking at oral bioavailability is based on healthy individuals. So you'll never get studies based on patients with altered GI anatomy or physiology. So that brings us back to why it's so important for the when we're looking at prescribed medications for our patient cohort, when we're looking at the first part of the journey, which is absorption, because sometimes we know because of our altered surface area or our altered transit times, we might not get the same level of absorption that a healthy individual, or not healthy individual because we are still healthy, but an individual who has full GI anatomy or physiology might get. Does that all kind of make sense? Okay, silence is golden. So again, this is just a diagram to illustrate why absorption is, and just a recap basically, is the amount of medication that reaches the systemic circulation, which is your oral bioavailability, but then you need to make sure you're having sufficient amounts of active form of medication that reach the sites to elicit the pharmaceutical response. Whereas you have patients, the majority of drugs are absorbed in the jejunum. We don't know exactly where, but the jejunum. Whereas with patients with pouches, sorry, I picked a J pouch picture, but as you know, there's different pouches. There might be, their jejunum might have reduced surface area, or you might have a faster transit. Also as well, caution, there are some preparations designed to release in the colon. So it's always important that you, as patients, and I try to tell my patients, and I know that the team at St. Mark's pretty good at doing this as well, try to inform the patients of their GI anatomy. So if any healthcare professional is prescribing you a medication, just make sure that they're aware of your GI anatomy, especially aware to get them to think, will there be any question in your absorption of the medication that they're trying to prescribe, and to make sure they don't prescribe you a medication designed to release in the colon. A lot more research is needed into this area, but fingers crossed we can get some done over the next few years. However, just as well for yourself, your healthcare professionals will monitor your clinical outcomes to all prescribed medication and alter as needed. So sometimes if we're not sure if we're going to get the right level of drug being absorbed, and we're not going to, we will monitor the clinical outcomes, and if need be, alter. So we could go for a higher than prescribed dose, or higher than recommended dose. But when you're going, or when healthcare professionals prescribe you higher than recommended doses, we've got to be careful that we don't cause side effects, because the higher the dose, the higher the medication that potentially could reach your systemic circulation and the site of action of the drug. And the higher the dosage, you could see more adverse effects of the drugs, and you could see more side effects. So when higher doses are prescribed as well, we do also monitor for side effects of the drugs. And we could, another way that we could try to boost the amount of drug in your systemic circulation is by shortening the durations between the administration of those drugs. So if it should be every 4 hours, we might say to you, take it every 3 hours, because we know we're going to get slightly higher drug levels. But again, it's the monitoring of your clinical outcomes, and it's the monitoring of any adverse effects or any side effects. Lastly, we can consider an alternative route. So if we've monitored you and we're not getting the clinical outcome we want, we could think to ourselves, could we use a different route than the oral route? Which brings us on to the main routes of drug administration. As I spoke to you before, we want to really get the medication into the systemic circulation, into your plasma, or your plasma. The majority of drugs, the oral route, and even if medication is prescribed via the rectal route, you first have to get the absorption from your gut, and then it goes to the liver, and could go to your plasma or go back to your bile. But just to keep it simple, you go to your gut, to your liver, to the plasma, and then back from the plasma and to the liver, to the kidneys, and then excreted. But if you know that we're having problems with this route and we're having problems with the gut, what we can do is use alternative methods. So we can go via your skin to your plasma. You can go intravenously, and that's directly into the plasma or to your systemic circulation. So you know there's no barriers with that one. Intramuscularly, muscle to the plasma. We don't tend to use this on a regular basis, and it's a very specialist administration. And inhalation tends only to really be for lung diseases, so we don't use it on a regular basis. But these are different routes that your team can consider. The problem with some of these routes are that they're very complicated. So if you're putting a medication directly from into your plasma, you need to make sure that you have access into your systemic circulation or into your blood vessels, which needs to be monitored and looked after to make sure it doesn't get infected. Intramuscular injections can be quite painful, so some patients don't like doing them on a regular basis. And subcutaneous preparations, also you need to be trained on how to administer those properly, and then train on how to store away any syringes or needles that you've used in the administration of that. Also as well, these routes, they're limited, so not all drugs are formulated in subcutaneously, intravenously or intramuscularly. So we are limited in the drugs that we have in these formulations. And then also as well, these formulations are very expensive. So some GPs are not able to prescribe them, and they are hospital-only prescribable medications. So that means if we have patients who live quite far away, we need to think about ways in which we can get their medication to them, or do they come back to collect it from us? So these are all considerations when we're trying to prescribe other routes. And we need to have very close monitoring of clinical outcomes when we're prescribing these routes. So it's a balance between, can we try to maximize your oral absorption, or do we move away from that to use different routes? So classifications of medications, this is the next section of the talk. So we have medications that are called prescription-only medications. These can only be prescribed by a healthcare professional with the relevant qualifications. So currently you can have, as you know, your doctors and your surgeons, they leave university as prescribers. We also have a number of independent nurse prescribers, independent pharmacy prescribers, and independent dietetic prescribers as well. So we all prescribe together as an MDT. Some of these drugs that fall into this category are Leperamide and Codeine. Leperamide and Codeine, so codeine is a prescription-only drug, and Laperamide, in the doses that we use Laperamide in, is considered a prescription-only drug.
Uchu, can I just interrupt there? Laperamide, the generic name being Imodium, is it?
Yes, Imodium. Yeah.
So a lot of people might know it by the generic name Imodium.
Brilliant. Very. Yeah. Do you know what? I'm so sorry. We're trained not to memorize.
Yeah, don't worry about that. I mean, no, it's just people might miss the fact. It's not a correction. It's just a clarification for people.
No. And forgive me. I'll note that for next time.
That's all right.
So they both act on the gut receptors. They reduce bowel movement. They allow more contact time for absorption, so hopefully increasing absorption of ingested food, water, medications, resulting in reduced bowel frequency and quantity. So Leperamide and Codeine. So with Leperamide, we can go up to 16 milligrams 4 times a day. I have seen sometimes going a little bit higher. It's more favorable than codeine because you don't get the sedation, and also as well, you don't get the dependence as well. Very little is absorbed from the GI tract. So we're talking about the oral bioavailability. If you've got a really good drug that's got good oral bioavailability, you get 100% of the ingested drug appearing in your systemic circulation. And let's say you've got, so if you have somebody who has no altered GI anatomy or physiology, if they take a drug that's got good oral bioavailability, that quantity or that amount will be 100%. But with Laperamide, the studies say that it's 0.3%, so it's got a really poor oral bioavailability. But with this drug, it doesn't really matter, because actually the mode of action and the receptors that Loperamide and codeine are targeting are based in your GI tract. And that's why you're getting the reduced motility from the GI tract, because it's actually targeting the receptors within the GI tract. Loperamide comes in capsules, tablets, liquids and melts. Liquids ideally are really only for pediatric patients. The melts, it doesn't mean that the medication is absorbed from your mouth or your buccal cavity. It's just, it allows it to be dissolved a little bit sooner when it's ingested. Codeine, the dose is 30 to 60 milligrams 4 times a day. Exceeding the maximum recommended maximum dose is not recommended. I haven't in my career ever seen it being done. It does also have some pain relief, and be cautious because it can become in combination with paracetamol. So sometimes I've seen patients who've been prescribed cocodamol and then prescribed codeine on top of it. So just be cautious if you are prescribed cocodamol and then prescribed codeine, just to try to make sure that you're not exceeding that maximum daily dose, and report that back to your healthcare professional. When the two of them are combined together, you do tend to get better outcomes. So Loperamide and codeine, how to take 30 minutes to 1 hour before meals. This allows the drug to start working before you eat. So you're getting that slowing of your bowel. And then so when you eat, the food has more time to have contact with the bowel, so increasing the absorption. Side effects, we've got to balance with the higher doses, especially for Loperamide. Loperamide can cause abdominal pain, bloating, nausea, and flatulence, so you've got to be careful of that. And codeine's main side effects is a drowsiness, headaches, low blood pressure, nausea, and vomiting. What you might see on a lot of warning labels, so when you're prescribed Loperamide or Imodium, the pharmacy warning labels automatically comes up to say no more than 8 in 24 hours. But don't worry, that's not for you. So your GP or your local community pharmacy might be like, oh, you're taking a very high dose, but it's just because we are prescribing higher than the recommended dose. And this goes back to the slide, one of the earlier slides, where it's saying that one of the things that we can do is prescribe higher doses than recommended. But because we know the amount of Loperamide absorbed is very little, and we also know that the receptors or the cells that Loperamide works on is in the GI tract, we're less worried about having systemic or body-wide side effects with Loperamide. Other things that you should that you could be prescribed is your vitamin B12, cytocobalamin. It's absorbed from the end of the ileum or your terminal ileum. So if needed, it can be given intramuscularly, and it's 1 milligram every 1 to 3 months from your GP or from your hospital. Vitamin D is absorbed from your jejunum. We know that a lot of people, a lot of our patients and general public are vitamin D deficient. So orally, it's well absorbed orally from your jejunum, so we can give the oral formulation, either on a daily dose or a weekly dose. But then also as well, if you're if your levels aren't coming up, or we're not noticing an increase in your levels of vitamin D, or we can give you the intramuscular injection, which is either from your GP or hospital as well. And as we were talking about monitoring clinical outcomes, for us, we can monitor the levels of vitamin B12 and vitamin D in your blood, so we know that actually we're giving you the right treatment for and it's working for you. So pouchitis, this is a paper that was produced by the hospital, by St. Mark's Hospital here. First line, we tend to use ciprofloxacin and metronidazole for 2 weeks. Second line, tinidazole and Rifaximin for 4 weeks. How to take these 2 antibiotics? It's to be taken regularly, taken at the same time each day, and ensure the timing fits around with your lifestyle. because it's really important that when you're prescribed medications like this, that you take them again on a regular basis and at the same time. So it really needs to fit in with your lifestyle. So if you're working, it's no good me saying to you, well, take them first thing in the morning and take them at 2 o'clock and take them at 3 o'clock if you're working night shifts, because that's not going to fit in with your lifestyle. So just always try to make sure that that fits in with you and the way that you and your family work. Don't miss doses, even if you're starting to feel better, because it's so important that you finish your course. One, to avoid antimicrobial resistance and any kind of relapse, which could lead to an escalation or treatment escalation. So ciprofloxacin, some warnings that you've got to be careful of if you're prescribed ciprofloxacin. It might impair performance of skilled tasks, e.g. driving, effects enhanced by alcohol, so you should avoid alcohol. And for a few days after, for 5 days after taking ciprofloxacin, avoid alcohol, because there'll still be ciprofloxacin in your system after you finish taking it. Because just give your body time to finish that pharmacokinetic journey and finish that elimination of the drug. Absorption of ciprofloxacin can be reduced by oral antacids such as calcium, iron, zinc salts, and dairy products. So give at least 2 hours before or 4 hours after taking ciprofloxacin before you take these. Metronidazole, avoid alcohol during the course and for 5 days after stopping. Again, those 5 days afterwards is to allow the body to finish the kinetic journey and eliminate the drug. Tenazole is from the same family as metronidazole. You can say maybe they're cousins if you wanted to look at it, if you're grouping families, drugs in family groups. So again, there's a possible interaction with alcohol, so that should be avoided as well. Rifaximin. Rifaximin is a little bit like Leperamide. You get very little rifaximin actually appear in your systemic circulation, so it's got a very low oral bioavailability. Because the main mode of action is in the GI tract. So that's a great one actually to treat GI infections. I know that in the past we used to recommend probiotics, especially VSL free, and that used to be able to be prescribed by the GP, but however, we're no longer available. It's no longer available for prescription via the GP or for the hospital, but you can buy it from pharmacies and local health food stores, and I think you can purchase it online. But the only thing I'd say to you, if you are buying it online, make sure you're buying it from a reputable source. It comes as a powder containing 8 strains of live freeze-dried lactic acid bacteria, and contains traces of soya, gluten, and lactulose. Or lactose, sorry. So if you have any intolerances or allergic to any of those, please be cautious. But again, lots more research is needed, and we need to write policy here in the trust actually for the management of pouchitis. Other prescription-only medications used, I've listed them here. So you're just aware that actually you can't buy these from over the counter. So moving on to prescription charges, I've put the link in where I've got this all from. As of the 1st of April 2021, the charge for a prescription item is £9.35p per item, which is a lot. However, if you're prescribed the same item, e.g. the same drug, same strength and same formulation, you only pay one item charge. And these items these prescription charges are enforceable or by local and hospital pharmacies. Who is exempt? If you have a specified medical condition and have a valid medical exemption certificate, also known as MEDEX. So medical exemptions. So for our, so I've listed. So if you look at the back of the prescription, point number E says has a valid medical exemption certificate. Who qualifies for this? I've listed all the conditions, but for us, it's anybody who that really applies to us is a permanent fistula. So in our case, a stoma. If you have a permanent stoma requiring continuous surgical dressings or applications. So you can apply for these for an exemption, and here's the website where you can apply for it. So medication the prescription charges are expensive. But having said that, I have a good friend of mine who's recently come back from living in America, and she says they're a lot cheaper than if you're paying the actual value of the drug, which they pay in America. So she was like, she doesn't mind paying the prescription charges. So I think it's all relevant the way that you look at it. Anyway, having said that, if you know that you are going to be using a lot of medication, prescribed medication from your GP over the course of 12 months, and you don't fall into the medical exemption category, you can do something to help with that cost, which is to apply for a prepayment card or prescription prepayment certificate. These are available from community pharmacists, your GP surgeries, and online and by phone. And if you, the website that I showed you earlier, you can go there for further information on that. 12 months, you pay 10 monthly direct debits, installment payments as well, so you don't have to pay everything up front. So if you have, so the savings, so the more prescriptions you have, the more savings, depending on if you're having a 12-month prescription prepayment certificate or a 3-month prescription payment certificate there. So they are good value for money if you know you're going to be using lots of items per month. So over-the-counter medications, also known as OTC medications, you don't need a prescription for these, and they're split into 2 categories. They're split into pharmacy medications only, and pharmacy medications must be sold under the supervision of a pharmacist. So you can only buy them from a registered pharmacy, and you can only buy them when the pharmacist is present in the shop. A general sales list medication, or GSL, that you might also heard it being called, you don't need any pharmacy supervision for that. But there are restrictions on the indications that these medications can be sold for and the pack sizes. So for instance, you can buy paracetamol. In boxes of 32, and that's a pharmacy-only medication, but you can buy them in packs of 16, I think they are, and it's a general sales medication. So that's an example of the restrictions. So talking about over-the-counter medications, just something to be cautious of. I pulled these sales figures for over-the-counter medications from 2020. They are a little bit skewed because of lockdown this year, I must say. But this is what the general public was buying in 2020. And as we're all members of the general public, I just wanted to talk you through the top 5, just to make sure that you had some hints and tips when if you wanted or needed to buy any of the over-the-counter medications in relation to having a pouch or your condition. So pain relief, this also includes topical and oral. Be very, very careful of NSAIDs because they can cause ulceration if you have in your pouch, and they can be very unsettling if you have IBD as well. So be very cautious, not only of oral NSAIDs, but topical NSAIDs as well. Also, NSAIDs interact with a lot of the medications that we prescribe to manage IBD or to manage pouchitis. So before buying any pain relief, I suggest you buy pharmacy-only pain relief and have a conversation with the pharmacist and let them know about your condition, and also let them know about which medication you've been prescribed so they can make sure that what they're selling you is safe for you. Vitamins and minerals, and also anti-tiredness. Again, when you're purchasing these medications, please think to yourself, have you had any deterioration in your absorption from any of the foods or drinks that you're absorbing? Is the tiredness, could it be due to reduced iron levels? So if you are thinking to yourself, oh, I just want to buying something, just also have a chat with the local pharmacist or your GP or your team here, just to see if they want to come in, and if they want you to come in so they can look at any of your blood levels to see if you need an oral or if you need an intramuscular or an intravenous top-up of whichever vitamin or mineral you're deficient of. Cough, colds and sore throats. Just be cautious. So these come in liquids. Some of the liquids, or a lot of the liquids, are sugar-free, so they contain sweeteners which could increase bowel motions and cause diarrhea. Also as well, some cold cough medicines also contain NSAIDs as anti-inflammatories, so be cautious that you're not buying anything that contains an NSAIDs. Decongestants can put up your blood pressure if your blood pressure is high, so also just be cautious of that. And again, I would recommend that you have a chat with your local pharmacist to make sure it's appropriate for you.
Uchu, if I can just jump in. NSAIDs being non-steroidal anti-inflammatories.
Yes, forgive me. Such as ibuprofen.
Yeah, ibuprofen is a particular one that people have asked about.
Yes, that's the main. Yeah, be very cautious of those.
Okay, so ibuprofen, would you be cautious because it might cause inflammation?
I will come on to that in 2 seconds.
Okay, alrighty.
Yeah. So
an associated question, sorry, is what's the best pain relief for long-term therapy for people with pouches?
So it depends on how severe the pain is, and where the pain is originating from. So people, in general, when you're talking about chronic pain management, you tend to start with things like paracetamol, which actually, when paracetamol is taken at its full dose and taken regularly, it's an absolutely fantastic painkiller. So we tend to start off with regular paracetamol, a dose that's appropriate for the patient, and it tends to be 4 times a day. And we ask patients to take that regularly. And then if the pain is not managed and controlled that way, we could look to introduce other therapies. We'd probably avoid NSAIDs. Another group we can introduce are weak opioids or strong opioids. But with the opioids, there is an element of dependence that could start. Also, as well, with opioids, you can potentially get not resistance really, but you can become tolerant. So you might need higher doses to elicit the same kind of pain relief. And also opioids, such as things like morphine or buprenorphine or fentanyl, they can cause your bowel to really slow down, and you can get very constipated from them as well, and adversely end up with a lot of abdominal pain. So we're very, very cautious. And what we try to do is to find out the nature of the patient's pain, and then try to treat appropriately. There are other things that we can try, such as medication that targets kind of more of a neuropathic pain, such as amitriptyline, gabapentin, but those all need to be managed very cautiously. So if we at St. Mark's can't manage that, we will ask your GP to refer you to a chronic pain service, who will have a full briefing of your clinical condition, of your GI anatomy and physiology, and they should hopefully be able to prescribe for you appropriately. I hope that makes sense.
It does, definitely. Thank you very much.
Okay. So just back to this slide quickly, gastrointestinal, so indigestive remedies, laxative, diarrhea treatments. If you're purchasing any of that, just think to yourself, has there been an exacerbation in your condition? Instead of buying something over the counter, do you need to actually get in contact with your skin, with your team here at St. Mark's or your team locally? Skin conditions or skin treatments, so infections, dry skin conditions. Always mention anything that you buy for your skin to your gastro team, because it could be an extra or intestinal manifestation of some gastro conditions. And also it could be a sign of reduced absorption of certain vitamins, trace elements as well. So avoid non-steroidal, so ibuprofen, diclofenac. They can cause ulceration in pouches and potential of bleeding as well. So just to touch very briefly on pregnancy and breastfeeding, it's really important that you work very closely with your medical team if you find out you're pregnant or if you're breastfeeding. And it really is weighing up the benefits versus risks, to make sure the benefits of taking the medication versus the risks to your pregnancy or a breastfed child. The safety data in pregnancy and breastfeeding There's no clinical trials. So normally when medications are licensed, they go through multiple clinical trials and are tested in healthy individuals and also tested in the individuals that have the disease state that the medication is aiming to treat. However, it's unethical to do this for pregnant women and breastfeeding women. So what they rely on is animal data or animal models. Sometimes these are hard to apply to human models, and many factors need to be taken into consideration when interpreting this animal model data and transferring it to human models. So we use a lot of general and basic pharmacology and pharmacokinetic principles. Also, as well, your team will look at your condition and the prognosis of your condition and potential outcomes or adverse effects of any increase or exacerbation of your condition to the pregnancy or to the breastfed child. And the healthcare professionals will help you make the right choice for you and your pregnancy or your child. So it's really, in cases like this, it's really a joint effort between the healthcare professionals and the patients to come to a plan or create a plan that's acceptable for everybody. So where to find information? In every medication that you are given, whether it be a prescription-only drug, a P medicine, a pharmacy medicine, a general sales list medication, there is a patient information leaflet found inside the box. And that is actually a really good port of call, and it gives you a lot of information. You can also speak to your doctors, nurses, and pharmacists. You have online sites, but I'd be cautious which sites you use and try to visit NHS sites. And there's lots of charities that support patients as well that have fantastic patient information as well that you can access. So thank you so much for listening, and I hope you found it useful. And again, thank you so much for the invite to talk to this evening.
Thank you very much indeed, Uchu. We have had a torrent of questions. How long have we got you for? Because I know you've got a long drive home.
I don't mind. The longer I leave at this, the better the traffic.
Well, that's very kind. Stop me if it gets ridiculous. But I'd really like to try and do, because you're such a source of information, I really would like to try and get through all the questions. So I'm going to try and bracket them together. On behalf of everybody, thank you very much in advance. So you mentioned about pain relief, a few questions around pain relief and the use of ibuprofen. And you were very clear that certainly for long-term use, ibuprofen would not be recommended, wouldn't be first choice. You'd be looking at paracetamol and then perhaps an opioid if paracetamol didn't work. So that's fairly clear. Are dissolvable tablets, oh, sorry, that's Imodium. Sorry, hold on. Does Laperamide use cause constipation?
It could do. So the way that Laperamide works is that you're trying to slow down because in your gut is made in the makeup of your gut, you have muscles. You have what we call smooth muscles. So they're different from, okay, I'm going to go back a few steps, but it will explain my answer a little bit better. So the muscles that you use in your arms, they're called skeletal muscles, and you can control them yourself. And you've got muscles in your body called smooth muscle, and these smooth muscles are autonomic and they're controlled via your brain, if that makes sense.
Yeah. So
your gut has what we call smooth muscle. So you don't voluntarily control that smooth muscle. So if you have a slowing of that smooth muscle, you can give drugs to stimulate it to make it go faster, such as senna. So if you have constipation, you can give something to get it going. But then if your smooth muscle is moving too quickly, you give drugs like Leperamide to slow it down. But obviously you might slow down your gut too much and then end up causing constipation. But the way that we prescribe it for our patients, we know that our patients have very, very fast smooth muscle, if that makes sense. So what we're trying to do is we're trying to slow down that smooth muscle.
Yeah.
But also as well, we know we can go too far. And there are some patients where we've had to cut down the Loperamide doses because we've really, their stoma output or their stool has become too firm. And we want to kind of, so we cut it back a little bit. So you can cause it, but it's rare in our patient population, if that makes sense.
Yeah. Yeah, I think Laperamide holds a very cherished place in the hearts of many pouchees. Just a comment, having sat on numerous forums. A question about Laperamide and availability from Colin. Are they only available on prescription, or are they available over the counter as well?
They are available over the counter, but when I talk to you about the restrictions on indication and the restrictions on pack size, with Laperamide, it's very restricted. It's only for diarrhea caused by non-infective mechanisms.
Yeah.
And it's at maximum of 16 milligrams per day. And the pack sizes are very small. So if you were to buy a Laperamide over the counter, the doses that we prescribe it for in our patients, you'd finish one packet per dose. So it'll become very expensive for you.
Yeah. Yeah, indeed. Thank you for that. Hold up. There's a very specialist question here about aspirin. It's from Isti. Essentially, the question is, would you recommend pouchees take aspirin to help prevent cancer? And the background to this is that Issy has a J pouch because of cancer and Lynch syndrome. She's part of the CAP3 project and took 300 milligrams of aspirin, which is stopped because of her surgery. Would you recommend that she takes aspirin still?
So as we talked about with the pregnant women, it's the risk versus the benefits. And I know for Lynch syndrome, aspirin is one of the mainstay therapies that they use. So with something so specialist as Lynch syndrome, I would definitely be guided by the MDT, the Lynch syndrome MDT. And I know that they use it, and I know that they're very good at surveilling for any problems with the pouches, to look out for any adverse effects. So if they have recommended for you, I would 100% take it.
Okay, that's great. Thank you. That's very clear. One more about ibuprofen. Does your advice against the use of ibuprofen apply to pouchees who have their pouches because of familial adenosis polyposis rather than the BD? That's from Lane.
I'm not too familiar with the condition, to be 100% with you. And with the ibuprofen, if it's something that the person has taken and it's been recommended by somebody who knows their condition better than I do, I would make sure that whoever has prescribed it knows that they have a pouch and understands what a pouch is. And because they've got the full details and background, I wouldn't want to give advice without knowing the full details, if that makes sense. Yeah. So I think in that case, because I don't know the condition too well, I would maybe recommend them having a conversation with somebody who knows their condition better than I do, and understands that they've got a pouch and understands what a pouch is, and the significance of non-steroidal anti-inflammatories on that pouch. Sorry, I know that's a very vague answer, but I don't want any bad advice.
No, that's okay. I think always best to be cautious, isn't it? Let's be honest.
Yes, yeah, no, definitely.
So, last one on motility. For Stephen Woods is asking about Lamotil. Will Lamotil be available in the UK again, and does it work differently from Loperamide?
Similar mode of action, and I don't know if it will be available again, to tell you the truth. It was discontinued quite a while ago, and it hasn't come back onto the market, so I think we've lost that one. Sorry.
Was it discontinued for commercial reasons rather than any health or?
Actually, I'm not 100% sure. I'm not 100% sure. I'll be honest about that.
That's right. Right, let's look at vitamins. Vitamins, if I can start off vitamins. So is vitamin B12 recommended? I think you've emphasised that yes, clearly it needs to be monitored and treated if necessary. This is from Stephen Woods. His GP has monitored his levels and say they're okay. So that's a verification of that.
That's great.
Okay. We do get a lot of comments on the forums about vitamin B12 and concerns that tiredness. Some people are convinced that it's caused by vitamin B12 deficiency, and when they're tested by the GP, their vitamin B12 levels are okay. Is there any possibility that tiredness could still be vitamin B12 deficiency, even if the levels are normal?
If your levels are normal, I would be. Any doctor or GP should be looking for the causes.
Yeah.
It could be is the patient deficient in any kind of, the patient got anemia, any lifestyle, are they actually getting enough rest? So there's a whole spectrum of things that I would, if your vitamin B12 comes back normal, then I think there's other elements of investigation that is available to the doctor or the MDT looking after the patient, and it might not necessarily be the vitamin B12. So I think it's in that case, then it's working with your healthcare professionals to make sure that, or they will make sure that the full investigations are done to make sure there's nothing else underlying that could be causing the tiredness.
I think I think what I'd add to that, if I may, is that if you take a blood test and your vitamin B12 is normal or within normal levels, then there's no clinical basis for your GP to do any intervention whatsoever. There's no rationale. They can't really do it unless that your readings are abnormal or there's another indication that you've got severe B12 emission. There's just they haven't got the mandate to do it if your levels are normal.
Yeah, it's true. Yeah.
Anyway, so Ruth. Hi, Ruth. Nice to see you again. Ruth asked the question, are there any vitamins we could take to keep our pouches healthy? I
don't know. That's the honest answer. I've not read anything recently. I don't know. Because what we have to do is any guidance that we produce has to be based on clinical evidence.
Yeah.
So nothing that I know of has been published recently. And then also as well, within our trust, we've got, and I suppose it should be a reassurance to patients that we've got very, very, very tight governance when it comes to our prescribing. So if we were to write a guidance on how to manage pouchitis or manage a healthy pouch, in order for that to be approved by our drugs, by our trust's drugs and therapeutics committee, we would need to provide them with robust evidence that actually we're going to be doing our patients benefit.
Yeah.
And I am not aware of anything that I could present to them to say, I would like to do this, and this is the reason why I'd like to do it. Please, could you approve it?
Yeah.
Yeah. So I think patients that are managed by St. Mark's can be reassured that there are very, very robust systems in place to make sure that anything prescribed to you is based on evidence and it's prescribed correctly for you and monitored correctly as well.
Ruth, did you want to come back on that?
Thank you. That was really great. But I was sort of thinking about lots of people say about whether probiotics help to keep your pouch healthy and whether it's an idea to take them as a preventatory measure for pouchitis or whether you should just take it if you've got pouchitis and do we absorb it in our small intestine?
So with the probiotic, I think it's the alteration of the gut flora. So it's, do you know how I was saying that some drugs that you're targeting the bowel, so the receptors could be in the bowel, but with the probiotics, it's trying to alter the flora of bacteria within your bowel. So you don't need to worry about absorption when it comes to probiotics. The reason why we can't prescribe probiotics anymore is because when NICE reviewed the evidence for probiotic prescribing, they thought that it wasn't there wasn't strong enough evidence to continue prescribing. So I suppose it's a bit of a difficult one. If the NHS has said there's not enough clinical evidence to support it, but there are a number of patients who feel that it's really helped them, and I don't want to take anything away from a patient's experience, because that is their experience and it has helped them. So if you do find it is helping you, then there's no harm in continuing, but we are restricted on what we can start, if that makes sense.
Do you have the gut flora in your small intestine as well as your colon?
Yeah, so there's gut flora in your small intestine and your colon, but the one that tends to be studied more is the flora of the colon, but you do have flora throughout your whole GI tract.
Okay, brilliant, thank you.
So the indication Vivo Mix and VSL, it's confined to helping to restore a healthy gut, a healthy balance of bacteria in your remaining gut after antibiotic treatment for pouchitis. So that's the indication. So it's for 1 to 2 weeks after you've had antibiotics will disrupt your flora in your gut. So that's why often people who take antibiotics get diarrhea along with the antibiotics. And that's because of disruption of the sort of healthy balance of gut bacteria. So that's what it's indicated for. And a lot of people take sort of Vivo Mix and VSL on a long-term basis and swear by it. But actually the indication is much more limited than that.
But then also as well, David, those people that swear by it, if it's working for them, then you can't tell somebody not to stop taking something that works for them, can you?
No, indeed. And they're safe, aren't they? There's not.
Yeah, there's very little. Yeah. Again, risk versus benefits. There's very little risk.
Let me ask you a great question here from Linda about prebiotics. So some US pouches are recommended to take lactulose as a prebiotic. Are there any prebiotics available in pharmacy?
No, not at the moment. It's an area that we need to get more clinical evidence for, so we wouldn't be able to supply any, unfortunately.
Linda, do you want to comment on that? I think the point there, are the prebiotics there to sort of feed the microbiome, to feed the bugs and encourage the right sort of bugs? Is that how they work? Yeah. Linda?
Yeah, I don't think it's right. I don't think there's any clinical papers written on it. I remember asking someone recently. But yeah, I just noticed on some of the J-Pouch pages from the States, a lot of, well, not a lot, but Dr. Shen seems to recommend some of them to take some very small amounts of lactulose, which is kind of like I think lactose as well, so you probably couldn't take too much of it anyway. But yeah, I was wondering if they have any alternatives for over here, just to help increase your good bacteria, I suppose.
No, unfortunately, we don't. But I think the best thing is if you eat a varied diet, you're going to get all of the goodness you need from your diet. So if you have a good varied diet, and they say eat the rainbow, yeah.
And we've got Gabriella Pufu talking about
yes.
dietetics.
This is a question for Gabriella.
Yeah. So there's a point where pharmacy stops and dietetics starts.
Dietetics start, yes. Definitely ask Gabriella this. She's
I'll quote
brilliant. And she'll probably give you, she will give you a much better answer than I am able to give you.
So I'm going to stick with Linda because she's also asked any type of potassium that allows better absorption for pouches.
There's just some that you've got to be cautious of. So we have things like effervescent tablets. So those tend to be our first line within the trust, and they're drugs such as Sandocaine. There's liquid preparations such as kali solution, which is helpful in some patients, but then again with liquids, you just got to be careful with because it's sugar-free and could contain sweeteners as well. There are modified release tablets, but they're less suitable for patients with altered GI anatomy and physiology. The reason why modified release preparations are less suitable for patients with altered GI physiology and anatomy is because they are designed to release in certain areas of the bowel. And if you don't have that section of the bowel, then you're not going to get the release. Or if you have altered pH in your bowel, then you might not be able to allow the bowel to release. Allow the preparation to release in the right pH, if that makes sense. IV therapies is another way to go if we feel that somebody's got very low levels, so we can bring them into hospital and have it administered there. And if it continues to be low, we can potentially see if we can set somebody up on home therapy to have IVs on a regular basis. Again, there's risks with IV therapies, and they're expensive as well, and they potentially could reduce somebody's quality of life if they're hooked up on IV for preparations. Another thing that you could do is if you're on EMIX, you can see if you can switch to double strength diaurolite because does contain about 40 millimoles of potassium. So those are the kind of things that we would use. To start with the effervescent tablets, you could consider liquids, avoid modified release, switch from EMIX to double strength diaurolite because it's got the potassium in there. And if all else fails, you can potentially consider, or your team can consider intravenous therapy for you if they feel that's appropriate.
Very comprehensive.
Thank you very much.
We'll come back to we'll do the last of your questions, Linda. So any tips for taking Creon for pouches, please? I don't know what Creon is.
Sorry?
What's Creon?
Oh, so Creon is a prescription-only medication, and it contains pancreatic enzymes. The pancreatic enzymes help digest. So let's say you need glucose. The form of so let's say you eat a slice of bread. That's a carbohydrate. Your gut has to break down the bread into its constituent parts, and in this case, it would be glucose, so the body can utilize it. So those enzymes help in the breakdown of ingested food and drink. So your gut is not only there to absorb, but also one of the functionalities of your gut is to chemically and mechanically break down any ingested food into a form that it can be absorbed from your bowel. So patients who have pancreatic insufficiencies, and they're not producing the right amount of enzymes to help the chemical breakdown of any ingested food or drink, we can replace that in the form of Creon. So the way that the Creon tablet is formulated to work is when you swallow the tablet, there's an outer coating, and the outer coating is designed to dissolve in the stomach. Now, when that outer coating dissolves, inside the actual capsule, there's lots of tiny, tiny little balls or spheres. And those spheres, what you want, the way it's designed is that those spheres will then mix as your stomach churns and starts to mechanically try to break down what you've ingested into it. The little tiny spheres of Creon mixes with that semi-solid form. And then so ideally, by the time the stomach is, by the time the food with the mixed creon is leaving the stomach, you have the little tiny spheres embedded throughout the semi-solid product. So when the food or ingested matter with the little tiny spheres moves out of the stomach and goes into your duodenum, which is the first part of your small bowel, the pH changes in that area. And then those balls are designed to break down in that changed pH. So what you then do is you get the mimicking of pancreatic enzymes, because that's the area, the duodenum is where you would normally get your pancreatic enzymes coming in. Does that make sense? So with Creon, you're just mimicking what your body would do naturally, but they've designed it in a two-phase process. One, for the outer coat to dissolve. Two, for the balls to mix through the food. And then when it comes out of the stomach, with the change in pH, then the tiny little spheres will release. And by that stage, because they're mixed throughout the food, then it can start working on the ingested food and drink to help break down that food and drink. So by the time it comes out of your duodenum and starts going down your jejunum, it should start to be, the food and drink should start to be broken down so your body can absorb the broken down products. I hope that makes sense.
Yes, thanks very much. I think I was making a mistake. I was taking it too much at the end of the meal, but when you explained it that way, it's sort of like, need to take it earlier on, otherwise it's kind of missed it.
Definitely, because you want that mixing throughout the food, because what you want is by the time your ingested matter leaves your stomach, those little tiny balls are mixed around in it. So if you take it with food or at the beginning of your food meal, that's probably the best time, because then the capsules hit the stomach when your stomach's relatively empty, so it can dissolve in that acidic environment. And then when you eat, your stomach's going to do that churning. Everything's going to churn and then it'll come out.
Thanks very much.
That's great. Thank you, Uchu. Howard, did you have your hand up? Oh, you're on mute.
Oh, sorry,
I did indeed. I did indeed.
Thank you so much.
Hope you can hear me now. Just two things, David. Uchu. The first, you mentioned Emix. I'm on Emix, Uchu. The problem I have to have a litre of it a day and only a litre of everything else because I get dehydrated. And A&E are a bit sick of me coming in, particularly during the summer, when things get a bit rough. The reason is because I'm a half and half. I have a pouch, but I also have a stoma, which is a temporary one, and I don't want to make it permanent. We won't go into that. What I want to ask you about Emix is I could get it all on prescription from yourselves, but it's much easier to buy the glucose from my pharmacy and the sodium bicarbonate. The problem I have is the salt. I've got it here. It's from you. I have to come to you to get this sodium chloride. Can I use things like table salt, or is there something you could recommend that would be just as good?
You can use table salt. And we have recently updated, well, I say recently, it was probably about 2 years ago, we updated our patient information leaflet within the trust to say sodium bicarbonate, sodium chloride, forgive me, and in brackets, table salt. So people know that they can use table salts. So forgive us.
Yeah, but no specific brand, no fine table salt. It doesn't matter what brand or what type of like fine salt. Table salt is good enough. That I wasted all my money. My God. The other thing is your conversation about Laperamide. Because you lose liquid and everything else, I've advised, Gavi's one of them, because she nags me a lot, bless her, to up it a bit. But the problems we have, as you know, we stoma patients, is it leak. When it leaks, you've got to be very, very careful. You've got to have it firm. I'd rather have it too firm and risk constipation than the other way around. So I'm taking about 1 or 2 a day rather than the 3 or 4 recommended. What do you think about that?
I would stick to the advice that you're given. But obviously, you know your body as well. So with Laperamide, if you think that actually your output is getting too firm, cut it down. If you think it's getting too watery, up it. And then when you speak to your healthcare professionals, ask them to give you a range, so you know which range to go in. And I think that we need to empower our patients. You're the best person who knows your body, if that makes sense. I can only give you advice, but actually I might be giving, but you know your body better. So if Gabby or your consultants or your nurses or even your pharmacists are giving you a range, then stick to that range, but then obviously alter it if you're getting a bit loose, or if you're going one way or the other.
I also have to have B12 injections quarterly, and also every 18 months, because I get tired, although I rush around like a bit of a maniac, as most people know. I have to have an iron infusion, which again, your colleagues do very, very well. But don't, the iron deficiency tablets are no good.
Yeah.
You can be allergic to them. It's trial and error of everything, isn't it?
No, definitely. And as soon as you find something that works for you, because we know, for instance, some patients are great on oral iron, so we always have to try somebody on. We can't, unless they were very, very deficient. We wouldn't go from a top approach to the bottom approach. Unless, for instance, somebody came in and their iron was completely non-existent, then we'd have to give them intravenous, because we want that into their plasma straight away. But for a lot of our patients, we try them on oral, and we try to maximize the oral, or we change the oral formulation, because there are different salts attached to the ferric. So iron, to give it its chemical name, is ferric. So we attach different salts or different carbohydrate groups to the ferric group to enable absorption to formulate an oral tablet. So there are different types of oral iron you can try. Some are more harsh to the bowel, and some are a little bit kinder to the bowel. So we do recommend that our teams try oral and try to maximize oral, and try some of the milder ones before we go to IV. However, if you are very deficient, we'll start with IV and then go back to oral. But then we know, just as you said, Howard, some patients, they just do not tolerate oral, so we won't bother with the oral, but we've tried it and we've ruled it out, and we'll just give them IV.
Lovely, thanks. Last thing, David, if I can just mention one other thing. You mentioned potassium levels in diaurolite. My potassium levels tend to start going up and up, so that's why I have Emix and I don't have diaurolite. What do you think about potassium levels, Uchu? I'm told it's dangerous. You get over about a certain level, you've really got to watch it. Is that true?
Yeah, potassium is incredibly dangerous because it can cause arrhythmias. And that's in your heart. It can cause your heart muscles to not conduct as they should do. So that's the risk with high potassium levels. So if anybody comes into hospital with high potassium levels, we act very aggressively and very quickly to make sure we're protecting their heart. And it is something that we see in our patient population, high potassium levos. And the reason why we see high potassium levels is that the content of your bowel is not very rich in potassium. So you're not losing a lot of potassium, but we're then giving you more potassium, if that makes sense.
Yes.
Whereas some people, they might struggle with their magnesium and their sodium, because the bowel content is very rich in sodium and rich in magnesium. So those are the two that we tend to look out for.
Lovely, thanks.
Thank you very much. Howard, it's £10 a question. Did I mention that?
You're going to get a good. You're going to get a good.
So I owe you about 150
100 quid, that one. Thank you very much. So let me come back to some basics here, because Teresa Parr's asked a very good general question here. Where can you find out where any drug is absorbed in the body? And I guess sort of the wider context is there a reference that pouchies can turn to regarding a drug advice, apart from looking at recordings of this presentation?
So this has become a bit of a passion of mine. At the moment, there isn't anything available, which is unfortunate. If you speak to the manufacturers, they will give you a rough guide of where the drug is absorbed in the GI tract, but they can't pinpoint it down. So I've had conversations with drug companies before where I've got somebody who's got 20 centimeters of their bowel remaining. And the drug company will give me a vague to say, yes, it's absorbed somewhere in the small bowel, but that's all they can say because they haven't done those studies to look into them. But there are different measures. So the pharmacokinetics I went through with you guys with the call on the call today. That's very, very basic principles, but there are other pharmacokinetic measures and parameters that you can use to kind of guess where drugs are absorbed. And so we know that some drugs are maybe better than others when we look at those markers. So it is, for us, as well, it is a bit of a guessing game. So we use the data from the drug companies, and then we use different pharmacokinetic parameters, and we try to make a good guess. But most importantly, you have to look out for your clinical outcomes or any adverse drug effects.
Yeah, it's difficult, that, isn't it? I mean, BMF is a very British methodology, but for a lot of people, they wouldn't have access to that, and a lot of people, lay people, wouldn't necessarily know all the terms. And
this is why, and so this is why it's so important to work with your to let prescribers know about your physiology for you. So when they're prescribing, if they don't know, they can go away and do some research, talk to a pharmacist, talk to a medicines information department, talk to whether it be within a hospital or within the drug company.
Yeah. Okay, let's change tack a little bit. You're doing really well. You're doing really well here, everyone. So let's talk about the microbiome, because now this, I appreciate as a pharmacist, this is probably at the very edge of your specialization. But there's a couple of questions about the microbiome, so I'm going to put them to you in the expectation that it's not really about pharmacy, but you may have a comment or an opinion. But the microbiome is increasingly, seems to be increasingly implicated in general health, both physical and also mental health, and the value of having a healthy microbiome being the gut contents, being the messy stuff in the gut, and having a healthy, balanced microbiome appears to have a lot of benefits, or beginning to. And we haven't got a gut, so we do have in the pouch, we get bacterial buildup, don't we? Which I guess is a quasi microbiome, as someone with a large intestine has. Is there any indication in pouches that reduced microbiome might be an issue for us?
To tell you the truth, you're right. This is at the fringes of my knowledge. But I do know there is an awful lot of research going on at St. Mark's about this. So I've not seen anything or read anything recently that gives me a conclusive answer that I can give to you that's evidence-based. However, I think in the next few years, a lot more will come out and a lot more will be published because a lot of people are doing some research about it. In my humble opinion, and this is my opinion only, it feels like if the microbiome is a whole new organ that we've discovered within healthcare professionals are discovered, and they're doing so much research to look into it, to see exactly what it means for us as human beings. And so I do think in the next few years we're going to see so much more come out. But at the moment, I don't know. But I would also encourage you to ask Gabby these questions.
Yeah.
I might give it a heads up and tell her to do something.
Don't worry about that. We're definitely going to ask. I think it's a fascinating area, and I would just add that
I think it's so interesting.
We as a charity, the Red Lion Group, makes a donation to fundamental research into gut-related issues and pouchitis and pouch-related issues, and we're funding research. We're helping to fund research. It's a modest amount, but we now have it written into our mandate that we will support fundamental research at St Mark's every year. So that's part of your membership. The small amount, a modest amount of membership, dear members, goes to fund that sort of fundamental research at St Mark's, which is greatly appreciated by St Mark's, and I know is really a really nice thing for us to do with the limited funds we have available. Right, back to the questions. All right, I've got a couple more coming in, hot off the press.
Okay.
Carol Garrett asks about very different topic, fibrogel. Is it suitable for J-pouch patients, or are artificial sweeteners an issue?
So the way that fibrogel works is, so fibrogel. Sorry, again, I'm really bad with brand names. Let me just double check myself. I think
Carol, do you know what fibrogel is?
It's spichula husk.
Yeah.
But yeah, I'm pretty sure it's spichula husk. So that is fiber, hence the name fibrogel. And the type of laxative class that it falls into is something called bulk forming laxatives. So the way that those laxatives work is that they will bulk up your stool and create a mass, so create pressure on the smooth muscle in your bowel, and then hence force the smooth bowel, the smooth muscle to move because there's pressure because of the bulk forming laxative. The only thing that we're cautious of, and the reason why we don't give a lot of fibrogel is that a lot of dietetic advice is to have low fiber diets, low fiber intake, and to reduce your fiber. So it's kind of counterintuitive then if we're prescribing something that is based on a fiber. And I spoke to you earlier on about how drugs have a pharmaceutical response on a receptor, but things like fibrogel, they elicit their response because of their molecule. So it doesn't work on any of the receptors. It's just because it bulks up, and that's the way it works. So I would be cautious. I would speak to, if you've been told to have a low fiber diet or a low residue diet, which is a more old-fashioned term for a low fiber diet, I'd be careful taking his spichula husk or fibrogel without consulting your medical team or your dietitian.
That's great, thank you, super. Now, you're doing really well. We had a number of questions, 3 short questions, tabled by someone who couldn't be here tonight. So I'm duty bound to ask them. They look quite technical here. So look, see what you can do. Okay. Is ozepresol useful for people with pouches? Ozepresol, Ozepresol. I've heard of it. Ozepresol.
Omeprazole.
Well, I wondered if it was that. Yeah.
Yeah.
Omeprazole is something for reducing acid, isn't it, in the stomach?
Yeah. So it reduces the volume of acid that you produce. So it reduces the volume of secretions that your stomach makes. So that's how omeprazole works. It doesn't reduce. Yeah, does that make sense? So it can work because it reduces so naturally your body produces about 9 liters of gastric secretions per day, and omeprazole reduces that. So if you do have high output stoma or you have a high frequency stool, omeprazole might help to reduce the volume that your body naturally produces.
Yeah. Yeah. Are the dissolvable tablets this is for Imodium? Are the dissolvable tablets more effective? We have had this, and there's also, I think, dissolvable things that go under the tongue as well.
So I think with some patients, we start with capsules. In this trust, we start with capsules, but some patients feel that the capsules appear in their stoma bag, and that could be because the transit of your stomach or your small bowel is just too quick and doesn't give the tablet time to break and release the active ingredients.
Yeah.
However, very early on in my career, I had a lovely patient who I worked with at the Royal London Hospital, and she reported that she was seeing the capsules in her stoma bag, but her outputs were very well controlled. So I spoke to the company who manufacture, and they said that they have had something called ghost tablets, where the capsule will appear in the bag, but it's released the active ingredients. So they told me just to monitor the patient's outcomes, and she was fine on it.
Yeah.
So if capsules are not working for you and you're not having a reduction in your or the desired effect on your outputs, we do then say to open the capsule and take the content of the capsule. And then the next step after that is, if that's not working, we can consider the melts. So if you remember that diagram that I had with the purple plasma, and there are some tablets that will absorb directly from your mouth. So you put the tablet into your mouth, and the drug will go into the capillaries in your mouth or in your buccal cavity and go into your systemic circulation. Laperamide doesn't work like that. Laperamide, the reason why the melts are sometimes better is, in order for a drug to be absorbed from your bowel, it needs to form a solution. So by giving somebody a Laperamide or a Imodium melt, you're starting that dissolution process in your mouth, if that makes sense. Yeah. Whereas if you were to swallow a capsule or a tablet, that dissolution process starts in your stomach. So you're just giving it a head start. So by the time it hits your the receptors in your small bowel, it's already in solution, or the solution formed higher up in the GI tract. Does that make sense? So it's not that. So it could be more effective for patients depending on the reasons why you failed the capsules or you failed opening the capsules. I don't know if that makes sense.
It does make sense. I'm just thinking about the profound acid environment in the stomach. So if you haven't got a protection for the drug as it goes through the stomach, then doesn't it just get, so something like the melts that dissolve in the mouth, I mean, they have no protection against the acid in the stomach.
No, don't worry about it. Yeah. So there's some drugs that if they hit an acidic environment, you'll knock out that drug. Yeah. So that's why insulin can't be given orally, because as soon as the insulin molecule hits the stomach, it then the stomach acids denature it. And this is why some biologic medications can't be given orally, because they'll be denatured by the acidic environment. There are some drugs that are fantastic in acidic environments, and the molecule changes slightly to allow them to become more absorbable. Yeah. So anything that's formulated for either a buccal or oral has its acidic environment.
Yeah, that's great. That's very clear. Yeah. That's super. So it passes through fine, gets to the active side.
No, don't worry about it. Yeah.
Yeah. Okay, great. Could be the last question here. Could be the last question. CBD tablets. This is cannabinoid tablets or cannabis for pain relief. Is that a good option for pouches? Is it a good option generally, whether you're pouchy or not? This is a new, recently approved medicine derived from the cannabis plant but regulatory approved for pain relief. Is that something worth? Howard, for example, could be taking that every night along with his other medications. That could sort him out good and proper.
I don't know enough about it because it's still very new, and especially for patients with GI conditions. And at the moment, it's restricted. If I remember correctly, it is restricted for specialist. Only very specialised consultant level clinicians can prescribe it. Yeah. So if you were to go down that route, I would suggest that you would already be in the chronic pain team, and there would be the prescription and the monitoring would come from them. So don't go out and buy it yourself until you've had a proper review. Yeah,
brilliant answer. Uchu, I think you have manage the marathon that is a red line group panel question time.
Thank you so much. I need a Blue Peter-esque kind of badge. I've done it.
We should do that. It's conventionally a bottle of wine, but unfortunately in these times,
don't worry.
David, I've got a quick question for
Chris.
Uchu. Uchu, it's something we chatted about a long time ago, and several people have asked me, not several, more than several, about free prescriptions. And is there anything currently going on at government level or NHS level, as far as you know? I know it's a difficult one to answer, but
Chris, I do remember this conversation. Actually, not long after we had that conversation, I think it was in 2019. So I think we spoke about it in the April of 2019, and in the June of 2019, I was at a pharmacy conference, and I bumped into an old colleague of mine who now works for NHS England. And we were just talking, catching up, and he told me what he does as his job. So I said to him, "Oh, do you know what? I went to this patient group, and I asked him, what can we do, or how do you get it reviewed? How do you get it onto the agenda?" And he said at the time hold fire. In 2020, we're reviewing all of this.
Jolly good.
I guess what happened in 2020.
Yeah. Okay. Yes. Okay.
So I do think that they're aware that there are some medical conditions that would require the exemptions. And I know that Crohn's and Colitis UK have done so much work on this as well. Yeah. I think that's where that they were, and this is something that he picked up with me as well when I was talking to him. He said that he knows that there's a lot of pressure coming from, well, not pressure, but a lot of representation coming from patient charities about this. So he said, "I'll hold fire, it'll probably be sorted out next year." But unfortunately,
Fingers crossed. Yeah. Thanks very much indeed, Uchu.
Fantastic, Uchu. May I say, we have had a cascade on the chat of gratitude and profuse thanks for your inspirational and educational talk tonight, and for staying on to answer a variety of questions with such energy and some enthusiasm. So from everybody on this event, can I offer a heartfelt thanks to you for your time and energies. And if I tell everyone that Uchu is still at work now and is yet to set out on a 1.5 hour journey home, perhaps it emphasises the sacrifice she's made to join us tonight and to give such a great talk. So thank you so much.
No, my pleasure, and thank you so much for inviting me. And I, as I said at the start of the presentation, is a part of my job that I really do find very rewarding. So it's my pleasure to be here with you all today. Thank you for inviting me.
I can also offer thanks to Gary for pressing all the buttons in the right way, and to Chris Brown, who managed to persuade Uchu so eloquently to give her time tonight. Thank you very much to you two both. There is a clinical trial going on at the moment for people who, I'm giving it a quick mention because this is a drug that's being developed specifically for pouchitis in patients who have recurrent persistent pouchitis. So these are people who have 2 or more attacks of pouchitis a year and for whom antibiotics don't always effect a cure. So if you're one of those people or you know someone who has that, there is a clinical trial going on of a new biologic which is specifically being developed for treatment of pouchitis, which is quite interesting because I don't think there's anything licensed for that. Certainly not in the biologicals anyway. So there's details on the Red Lion Group website, pouchsupport.org, if you're interested to read more. I'm delighted for you to do so. Apart from that, and thanking Uchu again, the next pouch or webcast, Red Lion Group webcast, is I think June the 14th. Professor Elsa Hart, who we haven't had before, so that's a new coup for Christopher. And Professor Hart, a great speaker, and is the head of the St Mark's Inflammatory Bowel Disease Unit. So really looking forward to that. and looking forward to seeing many of you are back again for that presentation. We also have the monthly pouch forums, patient forums. Bring along your own cup of tea or pint of beer or whatever. They're the first Monday of every month. So the next one, he says, scrabbling for his diary, is June the 7th. Pouch forum. So come along and share your pouch experiences, bit of fun and games with the rest of the pouch community on the 7th of June. Apart from that, once again, Uchu, thank you very much indeed. Safe journey home. And to you all, thank you very much for your attention this evening. Thanks again.
And just to add one more thing, since you've got the amazing Prof. Hart coming next, you should ask her about the microbiome, because she'll be able to give you fantastic